Welcome to this presentation on chest x-rays for finals. The aim of this presentation is to make you feel comfortable and confident in interpreting chest x-rays during your final exams. During the first part of this presentation, I will show you how to read a chest x-ray. Then I will explain important findings on chest x-rays to enable you to spot them. Below this presentation on YouTube, I have included links so you may go straight to any section that interests you. Finally, I will explain how to systematically review a chest x-ray so that nothing is missed. How to read a chest x-ray. The standard chest x-ray has a PA view. The patient faces the film cassette. The x-ray beam passes from posterior to anterior. There is a fixed 6-foot distance between the film and the cassette. If a chest x-ray is not labelled otherwise, it can be assumed to be a PA chest x-ray. In a PA chest x-ray, the patient will have their hands on their hips. This position moves the scapulae away from the lung fields. From this to this, notice that the scapulae are well out of the way. In contrast, an AP chest x-ray is performed when the patient is too ill to be transported to the radiology department. Therefore, the mobile AP chest x-ray is taken with the patient either sitting up like this or lying supine in bed. The patient faces the x-ray tube with the x-rays passing from anterior to posterior. Compared to a PA chest x-ray, there is a more variable distance between the tube and the cassette. AP chest x-rays will either be labelled AP, portable, or they will be labelled with the position that the x-ray was taken in this case supine. The first disadvantage of the AP is that the mediastinum is magnified. Look at these two chest x-rays. They've both been taken from the same patient. The chest x-ray to the left is the standard PA view. The chest x-ray to the right is an AP view. In the AP view, the mediastinum is significantly magnified. Therefore, accurate assessment of cardiac size is not possible on an AP chest x-ray. The reason that the mediastinum is significantly magnified in the AP view is because the x-ray tube is closer to the chest, resulting in more beam divergence. In addition, the heart is further away from the cassette in an AP film. This is a diagrammatic representation using corresponding axial MRI images. The second disadvantage of the AP is that the patient is usually unwell or intubated, sitting or supine. As a result, often a full inspiratory film is not possible. Due to difficulties with positioning patients for an AP view, rotation is often a problem. After identifying whether the chest x-ray is a PA or an AP view, we usually verify the patient's details. In other words, their name, date of birth, and the date that the chest x-ray was taken. There are 3 components to assessing technical quality on a chest x-ray: rotation, inspiration or inspiratory effort, and penetration. Rotation is easily assessed in the following way. The medial ends of both clavicles should be the same distance away from an imaginary line formed by the spinous processes. This demonstrates that the patient is not rotated. If the patient is rotated, then the imaginary line formed by the spinous processes, here shown in yellow, will not lie in the middle of the medial ends of the clavicles. The patient will be rotated in the direction of the furthest clavicle. In this case, the patient is rotated towards their right side. The diagram at the top represents what is seen on chest x-ray when the patient is well centred. In contrast, the diagram at the bottom represents rotation to the right. When a patient is rotated to the right, most of the mass of the right lung is shifted over the heart and away from the right lung field. This creates hypertranslucency of the right lung. The right heart border becomes more prominent. In addition, the true size of the heart may be underestimated, as can be shown on the diagram. This chest X-ray, which is rotated to the right, demonstrates both hypertranslucency of the right lung and prominence of the right heart border. However, in this particular example, the heart size is not smaller than normal. The diagram at the top represents what is seen on a chest X-ray when the patient is well centred. In contrast, the diagram at the bottom represents rotation to the left. When a patient is rotated to the left, most of the mass of the left lung is shifted over the heart and away from the left lung field. As a result, X-rays pass through less lung parenchyma on the left, resulting in hypertranslucency of the left lung. In addition, the heart size is exaggerated, as can be seen in the diagram. This chest X-ray, which is rotated to the left, demonstrates both hypertranslucency of the left lung and prominence of the left mediastinum, including prominence of the aortic arch. However, in this particular example, the heart size does not appear to be enlarged. Both of these chest X-rays are of the same patient. The chest X-ray on the left demonstrates good inspiratory effort, and the chest X-ray on the right demonstrates poor inspiratory effort. Good inspiratory effort should demonstrate the sixth anterior rib intersecting the diaphragm at the midclavicular line. The diaphragm is attached to the undersurface of the heart. The downward pull of the diaphragm is less when inspiratory effort is shallow. Consequently, the cardiac outline may appear larger. Poor inspiratory effort will also result in the crowding of the vessels at the lung bases. This will result in increased density, which may mimic collapse or consolidation. Penetration refers to the number of X-rays reaching the cassette. This is less of a problem now with the widespread use of digital imaging, which allows post-processing to correct for problems with penetration. Ideally, the thoracic vertebrae should just be visible on a PA chest X-ray. Underpenetration refers to not enough X-rays reaching the cassette. This is common in AP mobile chest X-rays, which rely on a generator rather than a fixed power source. This makes the interstitium and pulmonary vessels appear more prominent. Detail is lost at the lung bases, and detail is lost at the vertebrae. Now you know how to read a chest X-ray, I'll now explain how you can spot important findings. Left ventricular failure. Left ventricular failure is characterised by 4 chest X-ray findings. Firstly, cardiac enlargement. Secondly, calibre changes of the pulmonary vessels. Thirdly, lung parenchymal changes. And fourthly, pleural effusion. Almost all patients with pulmonary opacities due to left ventricular failure have cardiomegaly. The exception is after acute myocardial infarction, where patients may have pulmonary edema and a normal cardiac size. Normally, on an erect chest X-ray, the lower lobe vessels are a larger calibre compared with the upper lobes. In left ventricular failure, this is reversed, with the upper lobes having a larger calibre than the lower lobes. This can only be commented on from an erect chest X-ray. The radiological appearance of upper lobe blood diversion is usually very subtle and is often overdiagnosed. Lung parenchymal changes are sometimes called curly B lines or septal lines. On a chest X-ray, they may be located towards the bases of the lungs towards the sides. They can be very faint. This picture emphasises the location of the curly B lines. See if you can make out the curly B lines now. Curly B lines are formed by pulmonary edema. Curly B lines are formed by pulmonary edema collecting along the straight edges of pulmonary lobules. Pleural effusion is oedematous fluid. It collects like a cotton wool haziness around the hilar. It is often described as bat's wings. The reason why pleural effusion is called bat's wings is because the edge of the edema is sometimes scalloped with slight concavities like a bat's wings. This phenomenon is illustrated in the picture, which shows the scalloped edges of the bat's wings and the scalloped edges of the edema. The reason why edema collects in the middle of the lung fields is because the edema collects in the alveoli. This diagram illustrates how edema collects in the alveoli. Pleural effusion is oedematous fluid that builds up at the bases of the lungs, starting with the costophrenic angles, which are indicated by the red arrows in this diagram. Pleural effusions may not be present in mild pulmonary edema. When present, right-sided effusions usually precede left-sided effusions. This model shows the difference between the bat's wings, which is a form of infiltrate shown on the left, and the pleural effusion shown on the right, which push the lungs upwards. In summary, left ventricular failure is characterised on chest X-rays by cardiac enlargement, calibre changes of the pulmonary vessels, otherwise known as upper lobe diversion, lung parenchymal changes, known as curly B lines, and bat's wings and pleural effusions. Other pleural effusions. There are other causes of pleural effusion apart from left ventricular failure. This table shows the possible causes of pleural effusions. The transudates, which are located at the top of this table, are more likely to be bilateral pleural effusions. The exudates are more likely to be unilateral pleural effusions. Pleural aspiration helps to identify the cause of the effusion. Pneumothorax. This patient presents with chest pain. What is the diagnosis? It's a pneumothorax. There are two key findings for a pneumothorax. The visceral pleural line parallels the chest wall. Usually it's up against the chest wall. There is an absence of lung markings. In other words, an absence of vessels between the visceral line and the chest wall. If there is diagnostic doubt, a repeat chest X-ray can be performed in full expiration. This makes the pneumothorax easier to see because the lung density increases on expiration. A pneumothorax is considered small if the distance between the visceral pleura and the chest wall is less than 2 centimetres. These are usually observed. When the distance between the pleura and the internal chest wall is greater than 2 centimetres, this is considered large. These patients can be safely treated with aspiration. What is your diagnosis in this case, and what would you do? A tension pneumothorax develops when air continues to enter the pleural space but cannot exit the pleural cavity. Pressure builds and can obstruct venous return. A tension pneumothorax is called a tension pneumothorax because the mediastinum is under tension and so midline shift of a mediastinum is present. Attention pneumothorax is called attention pneumothorax because air pushes the mediastinum to one side, placing it under tension and therefore causing midline shift of the mediastinum. Once attention pneumothorax is diagnosed, a percutaneous aspiration should be performed with a 14-gauge cannula in the midclavicular line. 14-gauge cannulas are the largest and are orange in colour. A hemopneumothorax is the combination of blood or fluid with gas in the pleural cavity. In an erect chest X-ray, this appears as a horizontal air fluid level with no meniscus because of the loss of surface tension. Lobar collapse. It is important to be able to differentiate collapse from consolidation on a chest X-ray. This is because to the untrained eye they look similar, but the causes are different. Collapse involves loss of aeration of the air spaces. This is caused by obstruction of the supplying bronchus. This may be caused by aspirated material, mucus plugging, bronchogenic carcinoma, or by compression by an adjacent mass. Consolidation involves fluid filling the air spaces. This is caused by excess liquid. This may be caused by pulmonary edema, inflammatory exudate, inhaled water, or blood. Consolidation must be present on a chest X-ray to diagnose pneumonia. I will first explain collapse. Collapse results in displacement of a fissure. It may also involve elevation of the ipsilateral hemidiaphragm, and it may involve a decrease in the spacing between the ribs. Collapse can involve the whole lung. A lobe, bisegmental or subsegmental. Collapse of a lung results in a whiteout, which means diffuse opacity throughout the affected hemithorax, and volume loss, which may result in mediastinal shift to the ipsilateral side. Lobar collapse appears as an opacity with volume loss. I will now explain the chest X-ray signs of volume loss in each of the 5 lobes. Right upper lobe collapse. On a frontal chest X-ray, the right upper lobe has the horizontal fissure beneath it. As the right upper lobe collapses, the lateral aspect of the horizontal fissure rises. As the collapse becomes greater, the right upper lobe takes on a triangular appearance. The collapse continues superiorly and medially. As the collapse continues, the right hemidiaphragm is elevated and the right hilum is elevated. On this slide, both the illustration and the chest X-ray demonstrate total collapse of the right upper lobe. Right middle lobe collapse. On a frontal chest X-ray, a right middle lobe collapse has the horizontal fissure above it. When the right middle lobe collapses, it collapses downwards. The downward collapse causes loss of the horizontal fissure and loss of the right cardiac border silhouette. The collapse has a triangular appearance. As the collapse continues, the right hilar position does not alter because the right middle lobe does not have significant volume. This chest X-ray and the illustration both demonstrate total collapse of the right middle lobe. I will now describe right lower lobe collapse. On a frontal chest X-ray, a right lower lobe collapse has the oblique fissure above it. As the right lower lobe collapses, it hangs from the hilum. It presents as a triangular opacity. An additional sign of right lower lobe collapse is loss of the right medial hemidiaphragmatic silhouette. This chest X-ray and the illustration both demonstrate total collapse of the right lower lobe. I will now describe left upper lobe collapse. The left upper lobe lies superiorly and anteriorly in the chest, with the left lower lobe lying inferiorly and posteriorly. They are separated by the oblique fissure, which starts off by being more or less flat. As the left upper lobe collapses, the superior half of the oblique fissure moves anteriorly, and the inferior half of the oblique fissure moves superiorly. As you can see, this causes the veil-like opacity in the upper zone of the lung to reduce, and the veil-like opacity in the mid-zone of the lung to increase. This is an example of left upper lobe collapse. Notice the veil-like opacity. This chest X-ray also has a large left hilar mass that occluded the left upper lobe bronchus and caused the collapse. Collapse of the left upper lobe causes elevation of the left hilum. This chest X-ray is another example of left upper lobe collapse. I will now describe left lower lobe collapse. On a frontal chest X-ray, a left lower lobe collapse appears triangular. Left lower lobe collapse is frequently missed because it is partially obscured by the heart. Left lower lobe collapse causes volume loss in the left lower zone. This may cause the heart to shift to the left. Left lower lobe collapse also causes the following changes: a loss of the medial left hemidiaphragmatic silhouette, depression of the left hilar point, and increased translucency of the left hemithorax due to an overexpanded left upper lobe. Collapse may be isolated to a segment of the lung. This is a good example of a segmental collapse. The opacity itself is quite elongated and does not conform to the expected appearance of an enlarging mass. In this situation, a lateral chest X-ray is revealing. It can be seen that the elongated wedge shape is demarcated anteriorly and superiorly by the oblique fissure. This is collapse of the anterior segment of the right lower lobe. As the area of lung involved is substantially less than that involved in a lobar collapse, the associated signs are far less apparent. Collapse may be isolated to a subsegment of the lung. When this occurs, this may produce a linear plate-like shadow. Often this is referred to as linear, plate, discoid or subsegmental atelectasis. Subsegmental atelectasis is a minimal degree of collapse, as seen in patients who are not taking deep breaths, such as post-operative patients or patients with rib fracture or pleuritic chest pain. Pneumonia. In practice, the words collapse and consolidation are often used interchangeably. This is careless, incorrect, and leads to confusion. Collapse involves loss of aeration of the air spaces. Consolidation involves fluid filling the air spaces. Consolidation is caused by excess liquid. This may be caused by pulmonary edema, inflammatory exudate, inhaled water, or blood. Consolidation must be present to diagnose pneumonia. consolidation appears as fluffy cotton wool type opacifications. Air bronchograms are normal aeration of the bronchi. The bronchi are highlighted because they are surrounded by the fluffy cotton wool type opacifications of consolidation. Consolidation results in little or no volume loss. Lobar pneumonia appears as consolidation involving a lobe involving no volume loss. Air bronchograms can be seen. Notice that the area of consolidation has indistinct borders. This chest X-ray is an example of right medial lobar pneumonia. This is an example of right upper lobar pneumonia. This is an example of left upper lobar pneumonia. Bronchopneumonia results in patchy segmental opacification. This can involve multiple lobes. Bronchopneumonia is most commonly the result of Staphylococcus aureus infection. It is important to ensure resolution of lobar or bronchopneumonia. A chest X-ray should be repeated after 6 weeks. It is advisable not to repeat the chest X-ray before 6 weeks, as the chest X-ray findings may be persistent regardless of the clinical findings. If the chest X-ray is not clear at 6 weeks, respiratory review and/or CT scan should be considered because a neoplastic process requires exclusion. Chronic obstructive pulmonary disease. The clinical syndrome of chronic obstructive pulmonary disease comprises of emphysema, chronic bronchitis and bronchiolitis, which can be difficult to differentiate merely by clinical and physiological measures. Therefore, imaging is used to determine how much of the chronic obstructive pulmonary disease is due to emphysema. This chest X-ray shows the typical features of emphysemaceous lungs. These are flattening of the diaphragm, location of the diaphragm at or below the anterior 7th rib, depletion of blood vessels, and elongation of the mediastinum, which pulls the heart down and results in a reduced transverse cardiac diameter. Bulli may be present, particularly in the upper lobes. These appear as air surrounded by normal pulmonary parenchyma. Chest X-rays are performed in the diagnosis of COPD in order to help exclude other causes of symptoms, for example, carcinoma or consolidation. Nodules. Lung nodules can be solitary or multiple. There is a long differential diagnosis list for a solitary pulmonary nodule. Most commonly, the solitary nodule will be an artifact, neoplasm, or focal granuloma. A focal granuloma forms when the immune system attempts to wall off infections that it perceives as foreign but is unable to eliminate. This includes tuberculosis. The first question to ask is the lesion real? It may be the result of an artifact, for example, a button. In this chest X-ray, the opacities seen were braids of hair. Alternatively, it may result from superimposition of normal vessels, or it may be a lesion outside the lung. Whenever a solitary pulmonary nodule is seen, it is important to compare with previous chest X-rays. If a lesion is stable for more than 2 years, it can be deemed to be benign and requires no further follow-up or investigation. If there are clinical concerns for malignancy and no previous imaging is available for comparison, or the nodule is new, Further evaluation with CT and/or a respiratory review is recommended. Multiple pulmonary nodules have many potential causes. However, the concern primarily is multiple pulmonary metastases. Hilar enlargement. It is important to be able to assess whether the hilar are enlarged. This is because hilar enlargement may be caused by a variety of diseases. Causes of hilar enlargement include tumours, infections such as tuberculosis, sarcoidosis and borreliosis. 99% of the hilar silhouette is comprised of pulmonary arteries and veins. Most of the hilar silhouette is pulmonary veins rather than arteries. When assessing the hilar, there are four main questions: hilar position, hilar shape, hilar size, and how the hilar on the current chest X-ray have changed compared to their appearance on previous chest X-rays. With respect to hilar position, the left hilum should normally be somewhere between the same level as the right hilum and 2 centimeters higher than the right hilum. In other words, the left hilum should never be lower than the right hilum or higher than the right hilum by over 2 centimeters. If the left hilum is lower than the right hilum, then associated pathology should be suspected. For example, the left hilum in this chest X-ray is lower than the right. This is a case of left lower lobe collapse with inferior displacement of the left hilum. The hilar should have a V shape with smooth margins and no lumpy bumpy elements. This is a case of bilateral hilar lymphadenopathy, where there is loss of the normal hilar V shape. If the hilar appear enlarged, it is important to decide whether this is unilateral or bilateral. This is for two reasons. Firstly, unilateral enlargement could be due to an artifact caused by rotation or scoliosis. Secondly, although unilateral and bilateral hilar enlargement can be caused by similar diseases such as bronchial carcinoma, lymphoma, tuberculosis or sarcoidosis, bilateral hilar enlargement can also be caused by metastasis, pulmonary artery hypertension, borreliosis, recurrent chest infections or AIDS. As with any suspected pathology on a chest X-ray, it is important to compare with a previous chest X-ray in order to assess for interval change. This case demonstrates unilateral left hilar enlargement. The chest X-ray 6 months earlier was normal. This is a case of bronchogenic carcinoma. Air under the diaphragm. Patients presenting with an acute surgical abdomen should be investigated with an erect chest X-ray, as well as the standard supine abdominal X-ray. This is because if the abdominal pain is being caused by a bowel perforation, gas will collect under the diaphragm. Nasogastric tube placement. Nasogastric tube positioning should normally be confirmed by a trained specialist registrar or above. However, a study in the UK, published during 2014, found that 1 in 5 nasogastric tubes are misplaced above the stomach. This increases the chances of an aspiration pneumonia occurring. Therefore, here is some advice in case you are asked to assess the position of a nasogastric tube during finals. On a chest X-ray, ideally the tip of the nasogastric tube should be 10 centimeters beyond the gastroesophageal junction. This is due to the number of side holes in the distal tubing. This chest X-ray has a nasogastric tube that is correctly inserted. Its location is shown by the dashed line. The gastroesophageal junction is where the nasogastric tube passes into the stomach. The outline of the stomach may be identified by the stomach bubble. This is a different chest X-ray that has a nasogastric tube. Although it does not have a prominent gastric bubble, the outline of the stomach can still be seen. We can therefore tell that the nasogastric tube is too high up. Only about 2 centimetres is below the gastroesophageal junction, when ideally we would like to see 10 centimetres of nasogastric tube in the stomach. The most common malposition of a nasogastric tube is a result of the nasogastric tube being too short, coiling in the pharynx, or having the tip of the nasogastric tube 10 centimetres from the gastroesophageal junction. Another malposition of the nasogastric tube is insertion into the airways by mistake, with its tip in the right main bronchus. This chest X-ray shows a misplaced nasogastric tube that is coiled in the tracheobronchial tree. This chest X-ray shows a misplaced nasogastric tube in the lower lobe of the right lung with an infiltrate. An infiltrate is the accumulation of substances that should not normally be there. I have now discussed how you can find the obvious abnormalities on a chest X-ray. I will now show you how to conduct a systematic review of the chest X-ray. A systematic review ensures that nothing important has been missed. It doesn't matter what system of reviewing you have, as long as you stick to one and don't miss any areas. A useful system is ABCDD: airway, breathing, cardio, diaphragm and delicates. Also comment on man-made abnormalities, for example lines, pacemakers or a nasogastric tube. Airway: is the trachea central? Breathing: start at the apices and work down to the costophrenic angles, comparing both lungs to look for differences. Ensure that you inspect the apices, hilar, mediastinum and costophrenic angles. The hilar should be looked at carefully because they are commonly forgotten. Remember that the left hilum should never be lower than the right, except in dextrocardia, and both hilar should be of the same density. Look around the edges of the lung fields, assessing for pneumothoraces. Cardio: is there any cardiomegaly? Can you see the normal borders of the heart clearly? If not, consider consolidation or collapse. Are the cardiophrenic angles clear? Masses or pericardial cysts can obliterate this space. Look for any abnormalities behind the heart. There could be lung masses or a collapsed lobe. Make sure that the density of the heart on both sides of the spine is equal. Anything other than a very slight difference in density should raise the possibility of a lower lobe pathology. Diaphragm: both hemidiaphragms should be visible and not flattened. Are the costophrenic angles clearly demarcated? If not, do they contain any fluid? Check that the right hemidiaphragm is slightly higher than the left. This is due to the liver. Look for air under the diaphragm. Remember that a gastric air bubble on the left is normal. Delicates: look for fractures. Look for rib space narrowing suggesting collapse. In the soft tissues, look for black areas which may be gas, otherwise known as surgical emphysema. Thank you for watching this video, and good luck with your finals. If you have any questions, please feel free to post them in the comment section below.